Recording in progress.
Hello everyone, very good evening. This is your mentor, Dr. Nikhita, and I welcome you all to today's episode of RRR Series. Let's discuss postpartum hemorrhage from the module Postpartum Problems. Well, you all know postpartum hemorrhage is definitely a nightmare for all obstetricians, and it's one of the leading causes of maternal mortality worldwide. So let's go through the Green Top guidelines on the prevention and management of PPH. Definitely this will come handy. And without much ado, let's start off. Well, you all know. Now, what is PPH? PPH is excessive blood loss from the genital tract. Okay, now there is something called as a primary PPH and something called as a secondary PPH. Now, in primary PPH, it's the loss of 500 ml or more blood from the genital tract within 24 hours of the birth of a baby. And secondary PPH is abnormal or excessive bleeding from the genital tract between 24 hours and 12 weeks postnatally. So PPH can further be categorized based on the quantity into minor and major PPH, and major PPH is further divided into moderate and severe PPH. So in minor PPH, it is blood loss between 500 to 1000 ml. Major PPH is more than 1000 ml. Moderate is 1000 to 2000 ml, and severe is more than 2000 ml. Well, this quantification, yes, to a certain extent, it is advocated, but in some cases, like say a woman is anemic already, or she's extremely low, weighing very low weight, so then we could not use this criteria as a cutoff, and we would rather go by their clinical condition rather than measuring liter to liter, ml to ml. Now, causes for PPH, well, you all know the most famous 4 T's causes of PPH. It's the tone, trauma, tissue, and thrombin. And of course, the most common amongst all of these is tone. Now, let's look at some risk factors for PPH. And such women with risk factors should be definitely delivered in an obstetric unit which has a blood bank attached to it. Okay, so now the high risk women are the one with multiple pregnancy, and obviously they are at risk because of the factor of tone. They have hyper distended uterus, and they can have atonicity post delivery. History of previous PPH, again tone. Now in case of preeclampsia, then the thrombin factor, where there is derangement of the coagulation factors, platelets, and all those factors come into picture. Fetal macrosomia, again tone. Failure to progress in second stage, tone. Prolonged third stage of labor, tone again. Retained placenta is tissue factor. Placenta accreta is again a tissue factor. Episiotomy and perineal lacerations are all trauma factors, and general anesthesia is again tone factor. So these women with such risk should be categorized as high risk, or those women having risk factors for PPH, and should be definitely taken care and delivered in an obstetric unit with an attached blood bank. Now, how do you reduce blood loss at delivery? So you think uterine massage will help? If you do uterine massage, does it reduce the blood loss at delivery? And do you think it's a prophylactic for PPH? Well, the answer is no. The guideline says that uterine massage is not a prophylaxis for reducing PPH. Okay, and routine use of prophylactic uterotonics to manage third stage of labor, definitely yes. And I'll just talking to you about what kind of uterotonics to use. And for women without any risk factors for PPH who is delivering vaginally, oxytocin, about 10 units by intramuscular injection, is the agent of choice for prophylaxis in the third stage of labor. True, definitely. This is what we give, usually given after the birth of the baby or at the birth of the anterior shoulder. We give oxytocin 10 international units by intramuscular injection. Now, after cesarean, oxytocin 5 international units by slow intravenous injection should be used. Yes, this is true again. So these are the two different routes and dosage of the same drug, oxytocin. It differs after vaginal delivery and after a cesarean. Please note these have been asked several times in SBAs. Now, for women without any risk factors for PPH who is delivering vaginally, more than 10 international units of oxytocin by intramuscular injection is of use. Now, this is a false statement. There are several studies, RCTs done, which have proved that more than 10 units is of no benefit and 10 units is sufficient for prophylaxis for PPH. Now, there's another drug, ergometrin oxytocin combination, and it may be used in absence of hypertension in women who are at increased risk of PPH, as it reduces the risk of minor PPH. Definitely, this is true. Now, in the absence of any risk factors like hypertension, this medicine can be used in place of oxytocin alone. So, for women at increased risk of hemorrhage, combination of preventive measures is superior to syntocinon alone to prevent PPH. True, definitely. It does help. Now, moving on to use of IV tranexamic acid. So, dose of about 0.5 to 1 gram in addition to oxytocin at cesarean section will reduce the blood loss in women at increased risk of PPH. Definitely, yes, can be given, and up to 2 doses can be given 1 hour apart. Well, moving on to management of the third stage of labor, there are two thoughts of managing third stage of labor. One is the expectant management and the active management. And it has been proved in the trials and in various RCTs that active management of the third stage of labor reduces the PPH by almost 60%. So definitely we advocate the active management of third stage of labor nowadays. And expectant management is nothing but you allow the placenta to separate by itself. You wait for the signs of placental separation and the delivery. Whereas in active management, we use uterotonics as discussed before, and we advocate early clamping of the umbilical cord and controlled cord traction for the delivery of the placenta to reduce the blood loss. Now, this second point, early clamping of the umbilical cord, is a bit dicey. So there are several guidelines which says early clamping does cause lower birth weight and lower blood volume in the newborn. NICE guidelines says this. So we have come to a consensus that umbilical cord should not be clamped earlier than 1 minute from delivery of the baby if there are no concerns over the cord integrity or the baby's well-being. So if everything is okay, we do allow a minute before clamping the umbilical cord. So moving on to, some more yes or no questions. Ergometrin oxytocin has similar efficacy as oxytocin, but has 5-fold increase in side effects like raised BP, nausea, vomiting. Definitely true. That's why you will have to select your patients properly before giving this medicine. Now, prostaglandin F2 alpha, known as the prostadin commonly, misoprostol can be used in place of oxytocin for active management of third stage of labor. This is false. There have been several trials, several studies. Definitely nothing could be replaced for oxytocin, not misoprostol and not carboprost either. Now, this is the new drug. Use of carbetocin resulted in a statistically significant reduction in the need for further uterotonics compared with oxytocin for those undergoing a cesarean, but not for vaginal delivery. Now, this statement is true. Remember, when you're when you're doing a cesarean section, and there are now studies that prove that carbetocin alone will help a lot. but not in those undergoing vaginal delivery. Okay. Now, there's statistically significant difference between carbetocin and oxytocin in preventing PPH. It's false. Visual estimation of peripartum blood loss is inaccurate and is often underestimating. Definitely yes. So visual estimation, you can never depend only on the visual estimation. You should always go by the clinical picture. Okay, hence clinical signs and symptoms should be included in the assessment of PPH. Look for tachycardia, tachypnea, and a slight recordable fall in systolic blood pressure. So all this can be seen with a blood loss about 1000 to 1500 ml. And now suppose the systolic blood pressure falls below 80, then it is associated with worsening tachycardia, tachypnea, and altered mental status as well in cases of PPH in excess of 1.5 liters. Now, how do you go about managing PPH? So first we'll talk about minor PPH, that is blood loss between 500 to 1 liter, 500 ml to 1 liter, and the patient is not in clinical shock. First, of course, you'll have to gain an intravenous access. A single 14 gauge cannula is sufficient in this case, and you will immediately draw about 20 ml of blood and send for grouping and screening and full blood count, coagulation screening, and fibrinogen included. In such patients, you will take the pulse, respiratory rate, and blood pressure every 15 minutes and commence warmed crystalloid infusion immediately. Now, in cases of major PPH where the blood loss is greater than 1000 ml and the patient is continuing to bleed or she's in clinical shock, you will have to go with the ABC, assess airway breathing and evaluate the circulation, position the patient flat and keep her warm using appropriate available measures in your labor room, transfuse blood as soon as possible, and until the blood is available, you can infuse up to 3.5 liters of warmed clear fluids, that is crystalloids. Initially 2 liters of warmed isotonic crystalloids and later about 1.5 liters of colloids can be given. Mind you, do not use hydroxyethyl starch. And there is no use or additional benefit with special blood filters as well. So this is the table. You will start her on crystalloids, 2 liters of warmed isotonic crystalloid and later 1.5 liters of colloid until the blood arrives. And if the blood arrives, you will have to transfuse as soon as possible. Now, role of FFPs. You give FFPs based on the coagulation screening result. Now, if the PT and APTT are prolonged more than 1.5 times, then you'll have to administer 12 to 15 ml of FFPs per kg. Now, suppose the hemorrhage is ongoing even after giving 4 units of red cells, then you will have to administer 4 units of fresh fluorescent plasma. In case of platelets, administer 1 pool of platelets if hemorrhage is ongoing and platelet count falls less than 75,000. With regard to cryoprecipitate, 2 pools of cryoprecipitate if the hemorrhage is ongoing and fibrinogen is less than 2 grams per liter. Now, these are our therapeutic goals in the management of massive blood loss. You will have to keep this as your goal. You will have to keep the HP more than 8, platelet count more than 50,000, prothrombin time less than 1.5 times the normal. Again, APTT less than 1.5 times the normal, and fibrinogen greater than 2 grams. So if anything, whatever you do, you should have this therapeutic goal. Now, if no hemostatic results are available and the bleeding is ongoing, then after 4 units of RBCs, FFP should be infused at a dose of 12 to 15 ml per kg until you get the reports. And if hemostatic tests are not available, early FFP should be considered for conditions with a suspected coagulopathy like placental abruption or amniotic fluid embolism, where the detection of PPH has been delayed. Now, if PT and APTT is more than 1.5 times the normal and hemorrhage is still ongoing, volumes of FFP can be given in excess of 15 ml per kg to correct the coagulopathy. Now, some more true or false. So routine use of recombinant factor 7A is recommended in the management of major PPH. No, the guideline says it is not. The most common cause of primary PPH is uterine atony. Definitely, yes, it's the most common cause. Hence, the initial management of PPH therefore involves the measures to stimulate the myometrial contractions. Now, how do you do this? Ensure that the bladder is empty. You can put a Foley's catheter and leave it in place. Oxytocin 5 international units, slow IV, or ergometrin 0.5 mg by slow IV or IM. After selecting your patients who are not having hypertension. And oxytocin infusion can be accelerated up to 40 international units in 500 ml of isotonic crystalloids given at 125 ml per hour unless fluid restriction is necessary in a patient. Now, prostadine or carboprost 0.25 mg by IM can be given. Dosages can be repeated at intervals of not less than 15 minutes to a maximum of 8 doses. And definitely the contraindication for carboprost is women with asthma. Misoprostol 800 micrograms sublingually also works well. Moving on to the surgical intervention. Now, if the pharmacological measures fail to control the hemorrhage, and surgical intervention should be initiated sooner rather than later. So the first line surgical intervention is the intrauterine balloon tamponade, where uterine atony is the only or main cause of hemorrhage. You can put a Foley's or an intrauterine balloon tamponade that is available. You can use it and leave it in place for say up to 4 to 6 hours. Nothing wrong if you leave it even up to 24 hours. Ideally, it should be removed during the daytime when seniors are available, and it really works. It helps. So that is the first line surgical intervention. So other conservative surgical intervention may be attempted as second line depending upon the clinical circumstances and the available expertise. It's recommended that a laminate diagram of the brace suture technique is always kept in the obstetric OT, and always resort to hysterectomy sooner than later, especially in cases of placenta accreta or uterine rupture. Ideally, and when feasible, a second experienced clinician should be involved in the decision for hysterectomy. Now, hemostatic brace sutures, there are two types, B-Lynch and Heyman's. These are compression sutures and they're associated with a low complication rate, but they have a higher risk of uterine ischemia. It appeared to be caused when the procedure was combined with a vessel ligation, and it has no negative impact on future fertility. So this is how a B-Lynch suture is taken, and the diagram should always be kept in your obstetric theater. So B-Lynch is when there is a hysterotomy incision. You go from anterior to posterior, that is 2 centimeters below the lower part of the incision. You go inside and come out 2 centimeters above the upper part of the incision, go all the way around the uterus, and posteriorly you will have to go inside and come out for about say 3 to 4 centimeters wide. Then again go up, come down through the incision anteriorly like done before. Suture the hysterotomy incision, and then tie up the B-Lynch sutures. Heyman suture is when like the patient has had a vaginal delivery, she doesn't have a hysterotomy incision. You will have to just take two compression sutures parallelly to each other. Now moving on to what is stepwise uterine devascularization and internal artery ligation. First, you will ligate a single uterine artery, then you will do it on both sides. Look for bleeding, still not settling. Go ahead with low uterine artery ligation on both sides. Then go ahead with a single ovarian artery and then both ovarian arteries. So first line conservative surgical treatment to control PPH. Then when you have to consider the internal iliac artery ligation, a senior gynecologist or a vascular surgeon should be called and involved, since this technique requires high degree of surgical skill training and it can be associated with ureteric injury. Uterine devascularization techniques include internal artery ligation, and definitely, as I discussed, it does not affect the future fertility. Now moving on to what is secondary PPH. As we discussed, Primary PPH is when the bleeding has occurred within 24 hours after delivery, and secondary PPH is when the bleeding occurs from after 24 hours of childbirth to up to 12 weeks. So the most common causes of secondary PPH is infection and retained products. So what are the investigations that you do in secondary PPH? First, you take a high vaginal or endocervical swab to rule out infection, endometritis, and start off with antimicrobial therapy. And most of the cases, it will settle with this. Along with that, you can order for a pelvic ultrasound to exclude the presence of any retained products of conception. If found there are any retained products, you can go ahead with the surgical evacuation. And this should be supervised by an experienced clinician because there is a high chances of perforation during this time. Now, about this PPH, as I said, it is a nightmare for all obstetricians, and you should always be prepared in case PPH happens. So you should have an alarm system to alert the whole labor room, or your seniors on call, your colleagues, the blood bank, your anesthetist. And often we should do the drills, PPH drill in the labor room, so that the staff and your colleagues and yourself are well versed when something like this happens. Also, it's helpful to maintain a PPH box where everything that is required in a case of PPH is available. Once you open the box, everything, like including a Foley's catheter or a cannula, or even the drugs that needs to be given, the patient warming system, all that should be available when you open that box. So another important aspect is, of course, you manage the case now. The second important aspect would be the documentation. Nevertheless, documentation is extremely important. You should always have a scribe by your side who's writing down the events as you are taking care, because obviously you will not be able to write. You should ask a scribe to start writing the events with the timings included, when the bleeding started, what is the cause of the PPH, and what are you doing, what medicine was given at what time, when was it repeated, have you done the complete pharmacological therapy before going in for uterine tamponade or the conservative measures or a hysterectomy as it is. So you'll have to ask a scribe to keep a record of the events that have been happening, because documentation is extremely important. And always an incident report should be raised after a PPH for the quality purposes. Well, this was about the topic management of PPH. I hope it has helped you to revise for your exams. I wish you all a very best for your upcoming MRCOG Part 2 exams. And always remember to go through the tables of the Green Top guidelines before your exam. When you're really confused, you don't know what to read a day before exam, just go through the tables and flowcharts in the Green Top guidelines. It is really helpful. And also try to revise the percentages. If you've made any pocket book, try to revise from that. So with this, I'd like to conclude this talk on postpartum hemorrhage. I hope it has helped you for your revision. Yes, an important topic for the exam as well. See you then. Good night. Take care. All the best for your exam.
Thank you, ma'am.